Hey there, CyberMDs, and welcome to another USMLE Step 2 lecture. Today we're going to be continuing our conversation in cirrhosis and really be diving into the sequelae of cirrhosis. So without further ado, please remember to like, comment, and or subscribe so that we can continue to provide these educational videos to people all around the world. Let's get started. Before we really dive in, I just want to give a brief lecture overview. We will be giving an introduction over cirrhosis and reviewing some of the basic pathophys, and then we'll start talking about the complications and sequelae of cirrhosis, what to do for those things, the therapies and the management, and then we'll talk very briefly at the end, give a recap about some of the key takeaways for cirrhosis and its management and the management of its complications as a whole. So remember that cirrhosis is a chronic disease of the liver, and it's going to be characterized by the replacement of the liver tissue by fibrosis and scar tissue and regenerative nodules. And those are all things we're going to be talking about momentarily, and it's often a result of things such as alcohol abuse and hepatitis B and C, which we will review again shortly. But remember that the etiology and finding the etiology of this fibrosis, this scar tissue, this hepatocellular damage is going to be very important. Remember that there are some common causes or common etiologies of cirrhosis that can include viral hepatitis, typically hepatitis B and hepatitis C, as well as alcohol abuse or excessive alcohol consumption. Remember that non-alcoholic steatohepatitis and non-alcoholic fatty liver disease, those can be things that can cause cirrhosis in our patients. You can also have autoimmune conditions that end up leading to cirrhosis. And then there are some more rare causes such as Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency, PSC, and PBC, which are all things that can also lead to hepatocyte damage and subsequent cirrhosis over a long period of time. Now, again, remember that once we have some sort of etiology that's going to be causing this hepatocyte damage, we're going to get liver injury, and that's going to be that initial step, and that's going to be followed by inflammation, of course, and then in the recovery period, there's going to be this fibrosis and scarring. And that repair process isn't perfect. So instead of regenerating healthy liver tissue, the liver forms this fibrous scar tissue. And that fibrosis and the accumulation of extracellular matrix proteins, that's going to gradually replace the normal liver architecture. And that scarring and that normal liver architecture disruption is going to disrupt the liver's vascular structure, and it's going to impair blood flow, and it's going to begin exacerbating other conditions that exist. And then finally, you'll get this regenerative nodule formation. Again, as that fibrosis progresses, the liver is going to try to compensate by forming regenerative nodules of healthy tissue. And those nodules are going to be consisting of hepatocytes that have survived or regenerated in this environment of fibrosis. But these nodules, although they represent an effort by the liver to maintain function, their presence still further disrupts that normal liver architecture. And so again, that's going to disrupt the vascular function within the liver and start creating those that portal hypertension that we often talk about with cirrhosis and the sequelae of cirrhosis. So as we've seen, the pathophysiology of cirrhosis really disrupts normal liver function and architecture, which is going to lead to a spectrum of complications. Among those, ascites really stands out as a common and sometimes challenging consequence of advanced cirrhosis. So we're going to explore some of the intricacies of ascites, including the pathophysiology, diagnosis, and management, before touching upon other related complications. So ascites is going to be the accumulation of fluid in the peritoneal cavity, primarily resulting from portal hypertension, again, one of the hallmarks of cirrhosis. The increased pressure in the portal venous system forces fluid into the abdominal cavity. And then you also have other contributing factors, such as the imbalance between oncotic and hydrostatic pressures. Liver cirrhosis is going to compromise the liver's ability to synthesize albumin, and that's going to reduce the plasma oncotic pressure. Concurrently, hydrostatic pressure in the portal venous system, as we've mentioned, is increased. So overall, this is just really going to promote fluid leakage into the peritoneal space. Diagnosis of ascites often involves a combination of physical exam, history, and imaging techniques. Very often, ultrasound is used to clinch this diagnosis. And then a key diagnostic tool is also going to be the abdominal paracentesis procedure, which is going to allow for direct analysis of that fluid. So management strategies for ascites can include dietary sodium restriction, diuretic therapy, and in some cases a therapeutic paracentesis versus a diagnostic paracentesis. In a diagnostic paracentesis, you're really just taking enough fluid so that it can be analyzed, whereas in a therapeutic paracentesis, you're taking off as much fluid as you safely can. So let's talk about management of ascites and analyzing this fluid. So when we analyze the acidic fluid that's obtained through paracentesis, this is going to be really vital for managing ascites. The assessment helps in differentiating between transidative and exudative ascites, and that helps us identify potential and also helps us identify potential infections like spontaneous bacterial peritonitis. And that can really help us guide our treatment decisions. Other complications of ascites and of this like portal venous hypertension that we keep touching on can be hemorrhoids. And these are going to occur due to, again, the increased pressure in the portal venous system, causing venous dilation all the way in the anorectal region. Management of hemorrhoids in cirrhosis patients includes very conservative measures such as dietary fiber intake, sitz baths, and topical treatments. In really severe cases, procedural interventions could be necessary, but again, conservative management is going to be key here. You can also see caput, which refers to the visible network of dilated veins around the umbilicus, and that's again resulting from portal hypertension. And that's going to be a sign that this pressure in this venous system and all the collateral circulation involved has really just kind of reached its limit. And management of caput, it's not dangerous. There's nothing per se to do for it. It is a physical exam finding and a sequelae of cirrhosis. But really, you're just going to be focused on managing the underlying portal hypertension and cirrhosis of that patient. Next, let's talk about varices. So varices are going to be dilated blood vessels, typically in the esophagus or in the stomach, that develop as a result of the increased pressure in the portal venous system due to cirrhosis. And these are going to represent a very significant risk for bleeding, which can lead to life-threatening hemorrhaging, life-threatening bleeds. Effective management of varices and their complications is really a cornerstone of cirrhosis treatment. So let's dive into the approaches in screening and management and addressing upper GI bleeds. So routine screening for varices in patients with cirrhosis is recommended to identify those who are at risk of bleeding. So endoscopy is going to be the gold standard for screening for this condition, and that's going to allow for direct visualization of varices and assessment of their size and the risk of bleeding. Now, to manage this, the primary goal is going to be to prevent bleeding. And that's typically achieved through some sort of maybe non-selective beta blocker to reduce that portal pressure, and endoscopic variceal ligation for varices at high risk of bleeding. And then in cases where varices have bled or if there's high risk of rebleeding, you can do portocaval shunting, which is going to be the TIPS procedure, TIPS being transjugular intrahepatic portosystemic shunt. So you can consider that. And as well as, instead of ligation, you can also do something called banding. So you can basically imagine putting like a little rubber band around this dilated vessel that's showing and kind of just clamping it off from the rest so that there's no blood supply to it. So you can get ligation or banding as well. Now, what you're really trying to avoid, again, is for these to start bleeding. And then you have an upper GI bleed on your hand, and it's very dangerous. It's a medical emergency. And the initial management of upper GI bleeds is going to involve securing the airway, especially in an unconscious patient. You don't want them to aspirate from their esophagus or their stomach as this blood is coming up and they're vomiting this blood. You don't want some of it to go down into their lungs and start filling up their alveoli, filling up their lungs, or clotting off their lungs, making it impossible for them to breathe. You're also going to want to do volume resuscitation. So crystalloid solutions are going to be administered rapidly because those are going to be initially the most available thing, and then you're going to follow that with massive transfusion protocols and packed red blood cells if necessary, so that you can really manage their volume loss and their significant blood loss that they likely have. Antibiotics are going to be recommended prophylactically in many cases of suspected variceal bleeding in order to prevent infections such as spontaneous bacterial peritonitis, which patients with cirrhosis are particularly susceptible to. Proton pump inhibitors are used to reduce gastric acid secretion, although their primary role is in the management of peptic ulcer bleeding rather than variceal hemorrhage. Sometimes the GI doctors will ask for PPIs to be given to patients who have an upper GI bleed and are stabilized in the emergency department. There are some studies that show that I believe it can reduce the risk of rebleeding, and so sometimes they will ask for PPIs to be put on a drip for the patient to help with that. Octreotide, somatostatin analog, can also be administered in these patients. And again, that's supposed to reduce blood flow to the GI tract, thereby lowering the portal pressure and assisting in the control of the variceal bleed. Now, the role of TXA or tranexamic acid in variceal bleeding used to be a lot more controversial. So remember, TXA is an antifibrinolytic agent that can help reduce bleeding in certain clinical settings. However, its use in variceal hemorrhage is that you shouldn't do it. There's been a number of trials, particularly one called the HALT-IT trial, HALT-IT, the HALT-IT trial, that essentially showed no benefit in administering TXA to patients who have upper GI bleeds. So TXA is not recommended anymore, whereas previously for an upper GI bleed, it was recommended as it was thought to help stop the bleeding. So, in summary, the management of varices and upper GI bleeding in cirrhotic patients is multifaceted, as you can tell at this point. It involves a combination of pharmacologic treatments, endoscopic interventions, and then sometimes surgical or radiologic procedures. So make sure you get early detection through routine screening and timely intervention so that you can avoid the dreaded upper GI bleed in the emergency department. Now, let's talk a little bit more in depth about SBP, or spontaneous bacterial peritonitis, because that's, again, going to represent one of these critical infections that can occur in patients with cirrhosis and ascites. And its development is a marker of advanced liver disease and has significant implications for patient prognosis. So SBP is going to occur when bacteria translocate from the gut into the ascites fluid, facilitated by an increased intestinal permeability and an impaired local immune defense in the cirrhotic liver. This bacterial translocation is the primary driver behind the infection, resulting from a combination of factors including altered gut microbiome and decreased gastric acid secretion and immunodeficiency, all again associated with this advanced liver disease. The diagnosis of SBP is primarily based on the analysis of ascites fluid obtained through a paracentesis. So key diagnostic criteria are going to include an ascites fluid absolute neutrophil count, or ANC, of greater than 250 cells. So greater than or equal to 250 cells. So on a test, for example, they might give you a total cell count that is 275, but the absolute neutrophil count is only 240 of that, so that does not constitute technically SBP. So that's something to think about on an exam, and remember as a hard diagnostic criteria that it's the ANC being greater than 250 or equal to 250 cells. Additional findings can include positive ascites fluid bacterial culture, although cultures may be negative in, I think it's like up to 60% of cases. That would be something for you to look up on your own in case somebody pimps you on that. Clinical signs can include fever, abdominal pain, altered mental status, but SBP can also be asymptomatic, so be really vigilant in these high-risk patients. The management of SBP is going to involve immediate empiric antibiotic therapy aimed at covering the typical pathogens, mainly your gram-negative bacteria from the enteric tract, the GI tract, as well as some gram-positive cocci. Third-generation cephalosporins like cefotaxime or ceftriaxone can often be used or very typically used in patients who have SBP or suspected SBP. Albumin administration can sometimes be used within the first 48 hours, particularly for patients who have really high serum creatinines or really high BUN levels or really high total bilirubins. And it's been shown to decrease renal impairment and mortality in some patient populations. I'm not entirely up to date on that. I know that is something that is done sometimes, but just be careful. Albumin can be really expensive and can be hard to get your hands on in the hospital. So make sure if you're going to do this that you really think that it's going to help your patient. And then prophylactic measures are going to be crucial for preventing SBP recurrence. So there are some patients out there who get put on antibiotic prophylaxis who have previously had SBP, and their physicians were worried that they would have a recurrence of that SBP. All right, next up, let's talk about bilirubin and bile. So first, bilirubin, and mainly talking about jaundice, so some of the findings due to bilirubin complications. So jaundice is the hallmark of elevated serum bilirubin levels, and jaundice is going to manifest itself as this yellow discoloration of the skin and mucous membranes. And in cirrhosis, jaundice results from the liver's impaired ability to conjugate and excrete bilirubin. You can also see scleral icterus, and so that's going to be the yellowing of the sclera, often an early sign of jaundice, indicative of increased bilirubin levels. And then you can have dark colored urine, so the presence of conjugated bilirubin in the urine, which occurs when bilirubin levels in the blood are high, can give urine a very dark color. So managing those complications related to bilirubin accumulation primarily involves addressing, again, just the underlying liver dysfunction. Now, we can also talk about bile. So some of the findings for bile really just includes pruritus or itchiness. So this intense itching can be a common complaint in cirrhosis and can result from the accumulation of bile acids. And so pruritus in cirrhotic patients is often related to cholestasis, which is a condition where bile flow from the liver is reduced or blocked. And the management of pruritus may include the use of cholestyramine, a bile acid sequestrant that can help reduce bile acid levels in the bloodstream and alleviate the itching. You can also use something called ursodeoxycholic acid, and that may be beneficial in some cases, and that might improve the bile flow. Additionally, managing cholestasis involves, of course, optimizing the liver function and may require specific interventions depending on the underlying cause of bile flow obstruction. If they have maybe some gallstones leading to this bile flow obstruction and subsequent issues related to that. So in summary, if we're talking about bilirubin and bile, think about jaundice, scleral icterus, dark urine, and then for bile, the pruritus or the intense itching. All right, next up we have hepatic encephalopathy. So hepatic encephalopathy is a spectrum of neuropsychiatric abnormalities seen in patients with liver dysfunction caused by the accumulation of toxins in the blood that are normally removed by a healthy liver. Ammonia is thought to be a key toxin involved in the pathogenesis of hepatic encephalopathy, resulting from protein metabolism in the gut. So the management of hepatic encephalopathy really focuses on reducing the production and absorption of ammonia from the gut. So lactulose, a non-absorbable disaccharide, is first-line therapy as it lowers colonic pH and converts ammonia to ammonium, which is then excreted. You also have rifaximin, an antibiotic that reduces ammonia-producing gut flora, and that's often going to be used in combination with lactulose. Dietary protein restriction was historically recommended, but is now approached with caution to avoid any malnutrition, focusing instead on the quality of the protein and overall nutritional status. Just remember that lactulose really makes your patients poop a lot, and a lot of patients they hate taking this medication. So make sure that you have really good patient education, really help them understand how this is going to improve their ability to not have these exacerbations of hepatic encephalopathy and how it helps them in the long term, because on a day-to-day basis, this can be extremely uncomfortable for your patient. Also, we can talk about asterixis, and that's going to be a flapping tremor of the hands, and that's a characteristic sign of hepatic encephalopathy, and that's again resulting from abnormal brain functions due to the liver failure, where the brain is now unable to regulate motor control effectively. And then for estrogen, you have palmar erythema as well as gynecomastia. So both palmar erythema and gynecomastia are manifestations of altered sex hormone metabolism in cirrhosis, particularly the increased peripheral conversion of androgens to estrogens. The liver's impaired ability to metabolize hormones leads to an imbalance, with estrogenic effects becoming more pronounced. So you can get palmar erythema, which is the reddening of the palms due to vascular changes, likely related to estrogen's effect on blood vessels. And then you can get gynecomastia, which is the development of breast tissue in men, also attributed to increased estrogen levels, which can be a distressing symptom for patients. All right, let's talk briefly now about some cellular function and some coagulation issues. So for cellular function, remember that the aminotransferases, including AST and ALT, are enzymes that, when elevated, indicate liver cell injury. So in cirrhosis, if AST is higher than ALT, acute hepatocyte damage, often in a ratio greater than 2-to-1, that can often indicates a alcoholic etiology. Now, this is easier to remember for me. I had this explained to me one time that AST stands for a shot of tequila. So if AST is twice ALT, that is due to alcohol. And then ALT stands for a liver toxin. And so ALT higher than AST often indicates some other kind of toxin or hepatocyte damage. But just a quick way to remember that AST twice ALT, often in the thousands, can indicate liver injury due to alcohol. Now, keep in mind that cirrhosis is a chronic disease, so the AST and ALT elevations that you will often see in patients who have cirrhosis can be what we refer to sometimes as smoldering, where they're elevated but they're just slightly elevated, and that's kind of the patient's baseline. So don't put a ton of stock into making your diagnosis of cirrhosis off of the AST and ALT. Make sure you get the whole clinical picture, but just a few things to think about there. Alkaline phosphatase, or ALK-Phos, that's an enzyme that can be elevated in cirrhosis, particularly in cases with bile duct damage or cholestasis. And then, as we just mentioned, bilirubin levels can also be high in cirrhotic patients. Now, for coagulation, cirrhosis affects the liver's ability to synthesize coagulation factors, which can lead to complex changes in coagulation profiles. So your PT, your PTT, and your INR are all tests that measure the clotting tendency of blood. In cirrhosis, PT and INR are typically prolonged due to decreased production of clotting factors. The INR is particularly important for assessing liver function and coagulation status. However, there's this question of, is the patient hypocoagulable? Are they a bleed risk? We very, very often talk about cirrhotic patients being at risk for bleeding, for upper GI bleeds, and we're very always worried about that, especially if they have to go and get some sort of procedure done. We're always worried about their bleeding risk. But it's very important to remember that these patients can also be hypercoagulable. So let's talk about both of those things. So due to the liver's impaired synthesis of coagulation factors, so like 2, 7, 9, 10, patients with cirrhosis often exhibit a tendency to bleed. Now, at the same time, reduced levels of natural anticoagulants, such as protein C and protein S, can predispose to thrombosis. So essentially, in a cirrhotic patient, you have less clotting ability, or less clotting factors, so that you are a bleed risk, but those clotting factors that do exist are not being naturally anticoagulated, so those ones that do exist are at higher risk for actually thrombosing. So the patients can be hypocoagulable and hypercoagulable. So make sure you think about that. So that dual risk highlights the need for careful management and balancing the risks of bleeding versus thrombosis. All right, we'll also talk briefly about hepatorenal syndrome, which has a complex pathophysiology involving significant alterations in blood flow regulation. That's the big thing there. In cirrhosis, we have the portal hypertension, which can lead to splanchnic vasodilation, which in turn causes a reduction in effective arterial blood volume. That's going to trigger a series of compensatory mechanisms, including activation of the renin-angiotensin-aldosterone system, sympathetic nervous system, and non-osmotic release of vasopressin, all aimed at preserving renal perfusion and blood pressure. However, these compensations can ultimately lead to renal vasoconstriction and reduce kidney function, culminating in hepatorenal syndrome. So hepatorenal syndrome really just refers to everything I just talked about hurting the kidneys, but it's because of this hepatic cirrhosis, this hepatic damage. Now, the final sequelae or complication that we'll mention is hepatocellular carcinoma, or HCC. And the development of HCC in a cirrhotic liver is a complex process. It's going to be influenced by genetic mutations and oxidative stress, chronic inflammation, these regenerative nodules, dysplastic transformations, the liver's continuous cycle of injury and repair and cirrhosis, facilitating cellular DNA damage, promoting oncogenic mutations, eventual emergence of cancer. Additionally, the cirrhotic environment, which is rich in pro-inflammatory and pro-fibrotic mediators, is going to further exacerbate the risk. So, early recognition of HCC is going to be pivotal, and surveillance in patients with cirrhosis typically involves semi-annual abdominal ultrasounds, and in some cases can involve serum AFP measurements, although AFP alone is not going to be sufficiently sensitive or specific for screening. So the appearance of a liver nodule on imaging in a patient with cirrhosis should necessitate further evaluation with maybe some sort of contrast-enhanced techniques such as an MRI or a CT to really characterize the lesion and assess for hallmark features of hepatocellular carcinoma. So it's likely that you will be exposed to two pivotal scoring systems that are used in the context of liver transplant very often, and those are going to be the MELD scores and the Child-Pugh scores. So let's examine each of those tools. The MELD, or Model for End-Stage Liver Disease score, is going to be a numerical scale that ranges from 6 to 40, and it's going to be used to estimate the 3-month mortality risk in patients with end-stage liver disease. So it's calculated based on objective lab values like bilirubin, the INR, creatinine, and in some adjustments, sodium levels. The MELD score is used primarily to prioritize patients for liver transplant, with higher scores indicating more severe liver disease and a greater urgency for transplantation. The Child-Pugh score, on the other hand, is a system that classifies the severity of cirrhosis into 3 categories: Class A, which is mild, B, moderate, and C, severe. And that's going to assess 5 clinical features of liver disease: your bilirubin, albumin, INR, ascites, and hepatic encephalopathy. And each parameter is scored from 1 to 3, with a total score determining the class. However, the Child-Pugh score is less frequently used now than the MELD score for those liver transplant decisions. However, it's likely that you'll be asked about or exposed to both during your clinical rotations. Now, let's talk about some therapy. Of course, we want to talk about lifestyle modifications and diet modifications in these patients. The diet modifications, we talked briefly earlier. It was mentioned that protein restriction was previously a methodology and is still used in some patients even now, but just be very careful about that and always be monitoring their overall nutrition status. And then lifestyle modifications, obviously we're talking about cessation of smoking, especially if this is an alpha-1 antitrypsin patient, because they're also going to be at risk for lung issues. We're going to be talking about cessation of alcohol, and going to be talking about just making healthier choices overall, potentially sodium restriction, things of that nature. So make sure you include diet and lifestyle modifications as a part of your plan for the cirrhotic patient who has these sequelae of cirrhosis. Now, pharmacologic interventions are going to play a crucial role in mitigating these complications and enhancing patient comfort and potentially slowing down disease progression. So diuretics such as spironolactone, a potassium-sparing diuretic, is going to be one of the cornerstone of ascites management in cirrhosis. It helps counteract the aldosterone-mediated sodium and water retention, which is going to be very typical in cirrhosis. Often it's going to be combined with a loop diuretic such as furosemide, and that's thought to enhance the efficacy and manage the fluid accumulation more effectively. Antibiotics can be sometimes used prophylactically, as we mentioned, in patients who are at risk of SBP, and then will be used, of course, in patients who have an existing SBP infection. Beta blockers, non-selective beta blockers, maybe such as propranolol and nadolol, are utilized to reduce portal hypertension and prevent variceal bleeding, and that's going to work by decreasing cardiac output and splanchnic blood flow, thereby lowering that portal venous pressure. And then you have other things such as proton pump inhibitors that are used to prevent GI bleeding from peptic ulcers, which these patients with cirrhosis may be at an elevated risk for that. You have patients with cirrhosis who sometimes have insomnia, and so management may include non-pharmacologic approaches initially, but then careful use of sleep medications due to the risk of exacerbating hepatic encephalopathy. For patients who have cirrhosis due to alcohol abuse, they may need help with alcohol withdrawal. So benzodiazepines under strict supervision can be used to manage withdrawal symptoms in patients discontinuing their alcohol intake, and then you may have to move them to something else for long-term therapy for that. And then for pain relief, we would recommend, non-opioid analgesics are preferred, again, just due to risk of hepatic encephalopathy with opioids and exacerbation of those signs and symptoms. And then, generally speaking, acetaminophen would be safe at some reduced dosing. And then diabetes management is going to require careful consideration in these patients, especially given the liver's role in glucose metabolism. So insulin or maybe like a non-sulfonylurea oral hypoglycemics are often going to be preferred for these patients. And then antihypertensive used cautiously, considering the altered hemodynamics in cirrhosis and the potential for renal impairment, are all things to think about for our therapeutic pharmacologic options. And then we have some procedural therapeutic options. So paracentesis, we talked about, where you insert a needle directly into the abdomen that often has a catheter that you then remove the needle, have a plastic catheter in the abdomen, and you either drain off a small amount of fluid for analysis for SBP rule out, and then you may or may not keep the catheter in and continue to drain fluid, and that would be considered therapeutic. Paracentesis really helping the patient get comfortable, because having all of that fluid in there compressing on the organs in your abdomen is certainly not comfortable, and having that tension on your skin is certainly not comfortable. You also have the portocaval shunting or intrahepatic portosystemic shunt, aka TIPS procedure. So that's going to create a new pathway between the portal and systemic venous circulation within the liver, achieved by placing a stent between the hepatic vein and the intrahepatic branch of the portal vein, which effectively reduces portal venous pressure and can help manage complications like variceal bleeding and refractory ascites. And remember that while TIPS can significantly alleviate the symptoms, it's not without its risks, including the potential risk or increased risk for hepatic encephalopathy. And then we have liver transplant. So wanted to take a second to talk about this. It's important to talk about. Liver transplant's going to represent definitive treatment for end-stage liver disease and cirrhosis. And the criteria for transplant are often based on the severity of the liver disease, which is often quantified by the MELD score, which we spoke about, and specific complications of cirrhosis that impair quality of life or pose a risk to the patient's survival, such as recurrent variceal bleeding or refractory ascites, hepatic encephalopathy, or hepatorenal syndrome. And then remember that there's contraindications to everything just about that we do. So absence of contraindications to transplant, such as active substance abuse, uncontrolled systemic infections, or severe comorbid conditions that significantly reduce life expectancy. These are all things that may be contraindications to liver transplant. And that's going to be a very complex process. There's limited resources. There's limited livers out there for these patients. So it's going to involve careful patient selection, evaluation for eligibility, consideration of, again, that organ availability, and this is going to be a very much a multidisciplinary approach, and it's going to integrate the expertise of hepatologists, transplant surgeons, and other specialists to really optimize the patient outcome. All right, that's it. Thanks for sticking it out for another lecture. Again, please remember to like, comment, and or subscribe so that we can continue to provide free medical education resources to students everywhere. Please check out our website at www.thecybermd.com, where we're currently working on building an entire question bank for step 1 and step 2 to be free to students to help as a study aid, and really trying to get those things going. So give us some feedback, let us know what we can work on, and please remember to share us with your friends if you feel so inclined. Thanks so much. Y'all have a great day.